Thank you to Professor Fabbri for this kind invitation. It's my pleasure to be here to present one topic where I have not so much experience because I don't use very often in my clinical practice the results of randomized clinical trials. And I will try to explain why. Okay, what are clinical trials? I think that this is useful for me and for young fellows, not, of course, for Professor Tavazzo or the other opinion leader in this field, but clinical trials. And when I talk about clinical trials, I rely to randomized clinical trials, which is the best approach to the clinical trials, the last approach to the clinical trials. Clinical trials are studies that may show which medical approaches work best for certain illness or groups of people. What are tribulations? Tribulations are the difficulty in interpreting the results of clinical trials, are the problems that arise from clinical trials in the application of results of clinical trials to clinical practice. What do clinical trials? They explore whether a medical strategy or treatment or device is safe and effective. There are many stages of clinical trials. They begin from lab studies, human safety, expanded safety, efficacy and safety, efficacy and effectiveness. And all steps have critical tribulations. Clinical trials are one of the final stages of a long and careful research process. The process often begins in a laboratory where scientists first develop and test new ideas. As you can see, very often what works in clinical lab doesn't work in clinical practice. The results are different. Why? Because there are many problems with this type of evaluation of some strategy, drug, or device. Which are the results usually? They can improve patient outcomes or offer no benefit or causes unexpected harm. Tribulation for clinical trials, this is an editorial, and they pointed out that only 2% of eligible patients with breast cancer are entered into trials. And very often the trials are chosen very early because of type 2 error, failing because of inadequate numbers to find a difference that is actually present. Trial and tribulation, this is another editorial that points on the difficulty of change the clinical practice on the basis of results of randomized clinical trials. Which are the tribulations of the clinical trials? This design issues, patients' characteristics, trial design, all these problems which are related to the correct interpretation of the results of clinical trials. So what do you need to know when you design a clinical trial so you can minimize the likelihood of failure? Which are the causes of clinical trials failure? If you deal with drugs, maybe molecular issues, logistic issues, or study design issues. Molecule doesn't work. Why? Because they don't have sufficient biological activity or doesn't have a manageable toxicity. If the problem is biological activity and the drug has no biological activity at all, a clinical trialist can do little to salvage it. Any manipulation is usefulness. If there is biological activity but is different from what you expected, the program can be redirected. Toxicity. Is predictable, you can modulate the study. Is not predictable, you leave the study. Every molecule has toxicity, and the job of the clinical trial is to design around them. Logistic issue. Half of the published preclinical experiments may be unreproducible. Very common to find good clinical practice issue in clinical trials. The most common logistic issues have inadequate sample size, and this is one of the biggest problems. Error in clinical trial design is the most common reason of failure of clinical trials. Selecting the right patients or selecting the right endpoint. The endpoint is different. Many times you have a good idea, a good design of the study, but the endpoint is not correct. So you cannot find the right answer to your question or select the right dosing of drug many times. Clinical design. A drug has biological activity but is tested for the wrong indication. It happens very often. It is tested in the right indication but in the wrong subpopulation, because when we study, when we have one randomized clinical trial, the population is very selected and the wrong dose or dose interval is selected. To isolate the biological effect of therapy, a randomized clinical trial needs to maximize its use in the group randomized to receive it and minimize its use in the comparison group. Very often, the number of patients treated with the drug which works in this subpopulation is much higher than placebo control. And this is one artifact to maximize the effect in the subpopulation study in respect to the control placebo group. This can create scenarios in traditional randomized clinical studies that vary substantially from care provided in routine clinical practice. Is completely different. And one example, some year ago, I was impressed from this editorial, you know very well, cardiac failure, Quo Vadis, from Dick Lutzeert. Lutzeert is one of the physiologists who designed the history of cardiac failure, the physiopathology of cardiac failure. And he had one question: why is there stagnation in the clinical management of patients with heart failure? The research concluded, research on the pharmacology, genetics, and the molecular biology of heart failure has in the past 30 years thrived as never before. And paradoxical, no new drugs have been successfully introduced over the past 10 years since the angiotensin receptor blockers. Why? If you see this slide, this is the introduction of digitalis in the treatment of heart failure in 200 years ago, more than 200 years ago. And without any randomized clinical trials to validate its use in heart failure. And at the moment, one of the last ESC guidelines, 2012, you see that is present in class 1B in many situations. So digitalis, without any randomized clinical trials, is still present in the clinical care of patients with heart failure. And some years ago, we invited, our gastroenterologist invited the one scientist who had the Nobel Prize for the discovery of the role of cytomegalovirus or in Helicobacter pylori in the pathogenesis of ulcer. And he said, if I should validate with randomized clinical trials my discovery, I will never have Nobel Prize, because I presented this my observation, and immediately was accepted. So this is the difficulty to understand why we moved from clinical megatrials since the introduction of the evidence-based medicine. We do one immediate correlation between the results of the trials and the evidence. Evidence of what? Because we have many trials with different results. So which is the evidence? Which trial gives us the evidence of that one treatment, one strategy works or not? Each one selects the trials which is confident with personal experience. So we should move, maybe later Professor Tovazzi will talk about this, we should move from guidelines to mind lines where personal experience can interpret much better than the statistical results, the significance of one strategy, one drug, one treatment. So the emphasis evolved from towards clinical trials with the simple measurement and the statistical correlation of so many parameters as large as possible in the larger patient population. So we shift from the conceptual, physiological or hypothesis-driven thinking behind the statistical correlation was often unnoticed. So we now evaluate all these results in a statistical thinking manner. So this is good? I don't think so. So our discipline, our clinical practice is direct not from conceptual thinking, where measurement and conceptual thinking are equally important, but now we think only exclusively on data acquisition, on statistical correlation of random instead of concept-justified measurement. This is a very big problem of this. So when you are in clinical practice, when you treat one patient, very complex patients, somebody says, but the last randomized clinical trials and the last guidelines says that we should move in this direction, and this is the tribulation of this study. This was the conclusion of Brutzert was that this shift from conceptual thinking to statistical thinking create this very big error of diastolic heart failure. Doesn't exist diastolic heart failure, exists heart failure. So the failure of several of these clinical trials has revealed that a clinical syndrome as complex as heart failure cannot be answered by asking simple questions and by imposing too strict exclusion criteria when selecting patients. I put here one slide I use when I talk with my postgraduate fellows. And if you see, and it's very schematic, which are the relationship, how difficult it is to select just one point to conclude that one situation can, or the control of one of these parameters can give some answer to the question of treating heart failure. You see that this is really not possible. Because also there are many other problems, diversity, polymorphism, pharmacogenetics, and the pharmacogenetics that supports the idea of heart failure as an information-rich patient-specific state. Because if we want to move from the general medicine to personalized medicine, where the environment is important, but also one half of the importance is related to the genetic of all disease, all complex diseases, as one genetic substrate. So another problem is the efficacy. One trial can say only that there is efficacy in this subgroup population, but the effectiveness is another concept, is how well a product works in practice, in clinical practice, in different population, in a very broad population, and we can have only one possibility, that if you have one study very large in one very less complex situation, yes, we can have the efficacy which is very close to effectiveness. But if you have one complexity of treatment very high and the smaller size of the trial, this is not possible to conclude it, to consider efficacy equal to effectiveness. So when we talk about guidelines, you have to take in consideration all these problems. Which are the Achilles heel of randomized clinical trials? There are many. We already talked about something of this. I don't want to repeat. Patient selection limitation. And here there is the list of top 10 clinical trial failure in 2012. And to treat some trial which was very important, the trials about the antioxidant. I spent some months in Sweden with my friend Tom Sardini, who was involved in study of antioxidant in preventing atherosclerosis, and all the trials at the time I don't remember, but it didn't work. Why? Antioxidant. Now the concept of atherosclerosis as an inflammatory disease related to the oxidative stress, which begins the cascade of events which lead to formation of the plaque, is universally accepted. But why antioxidant, which work in this field, doesn't work in clinical practice? There are many reasons. Some reason is here. Some hypotheses. Most antioxidant therapies that have been tested, they were not chosen because they were proved to be the best antioxidant, but rather because of their easy availability, like vitamin E. And the trials have not lasted long enough. We tried to treat one very long and complex disease with one short intervention with drug. And if it was possible to reverse one very long disease with this intervention, this idea was uncorrected. So the trial failed not because there is some problem in the evaluation of the results, because the idea was not correct. It was not applied correctly. The idea that antioxidants should work in, if you give this antioxidant for all the life, to counterbalance the effect of oxidative stress which is present continuously in our organism. Okay, it could work, but if you give for 6 months one antioxidant, and you think that it is possible to reverse one very long process, it doesn't work, of course. The lack of benefits in clinical trials to date does not disprove the central role of oxidative stress, but it is impossible to show the benefits of antioxidant therapy, as I said before, over several years, if the therapy is trying to reverse the results of several decades of oxidative stress. And the failure of this trial, because this trial gave some problem in electrolyte situation, and also gave some increase in blood pressure, so it doesn't work. And it's clear from logical and experimental point of view that the increase of HDL, the decrease of LDL should decrease the amount of atherosclerosis. So there are many problems, and the statistical analysis is not enough to interpret the result of this trial. Also the dynamic trial for the use of early invasive strategy in acute coronary syndrome, and also the FISC trial, they compared not the use of the superiority of early invasive, the efficacy of primary PCI, but the efficacy is primary PCI doesn't mean that you can use this strategy in all patients with acute coronary syndrome. So the different results are related also to this problem. And these are the tribulations of clinical studies, but fortunately, most final clinical trials are never published. So we don't know how many clinical trials are not published. And I would like to finish with this slide. And to just for young people to send one message that now I see with my young fellow, they don't study the pathophysiology of the disease. They know very well all the results of the clinical trials, the guidelines, but the guidelines are constructed on the results of the clinical trials. Two clinical trials, two randomized clinical trials, or two small meta-analyses are able to put one procedure, one treatment, one drug in class 1A. And people think that this is evidence. There is no evidence at all. There is the evidence of this trial in this subpopulation study. So the results of the clinical trials apply only to this sub-study population, which is very different from the population you have to treat, you deal during the clinical practice. Thank you.
Thank you, Professor Romeo. I can see Professor Bax already. Did you raise your hand, Gerald? Please. Professor Bax as being chairman of the guideline committee of the European Society of Cardiology, so his contribution is really focused.
Thank you very much for the excellent lecture. I was sitting outside there just to listen to your talk. And I think the dilemma that you indicate is something that we see in all these trials, that you have the so-called responders and the non-responders, and this became more and more clear with the devices that we've been working with. So I share with you the concern between, on the one hand, the cohort sort of approach, and on the other hand, the personalized medicine. What is your personal view on how to proceed with the trials in personalized medicine? Because I've been thinking about that many times, and I have very much difficulty to see how we could move that. But I agree with you that this is probably one big step forward.
Yes, I think that today I work very strictly with my genetist, who now is also my rector, and I began to work with him about the genetic of atherosclerosis. It is not possible to apply only the results of environment treatment to the atherosclerosis. Atherosclerosis is a complex disease where the phenotype expression is the result of one interaction between genetic susceptibility and environment, cholesterol, diabetes, and so on. I think that we should send one warning to say this trial, the result of this trial apply to this population, to this subpopulation. And if the trial is well conducted, maybe is correct. But to extrapolate and to put in class 1A the results of two small trials or two meta-analyses. Not in this presentation, but when I talk about the early PCI after myocardial infarction, there is a debate from many years ago. And from the beginning, based on conceptual thinking, for me, it was important to treat immediately patients who did thrombolysis, because many years ago there was an editorial, The Illusion of Thrombolysis. Many patients with apparently efficacy of thrombolysis had close, complete occlusion of the related artery. So we say, okay, immediately after the thrombolysis, if the patient stabilizes, you have to send the patients to one referral center to do PCI. And there was another thinking. No, you can wait. You can do some analysis, some control. And I did this for 10 years. And all the trials were in favor of delay of PCI after initial thrombolysis. At the end, transfer-dynamic, caress-dynamic study demonstrated that the difference was between 4.1 to 11.1 in mortality. So for 10 years, these groups had 7% of mortality, 11 versus 4%, 7% is very high mortality. When immediately the hypothesis driven or conceptual thinking approach was clearly in favor of immediate PCI after thrombolysis. So we have to shift from immediate only merely analysis of statistical results of two trials, more trials, because in the history of cardiology, all trials, one trial was in favor, the second contrary. So, which is our behavior in this situation?
Thank you, Professor Romeo. I think we will be back on this topic, so the discussion will be open again.